This chapter is over fluids, electrolytes, and acid-base balance. And you're going to find that it's going to have a lot of information that we talked about before, but this chapter puts everything together. Some of the concepts that we learned about in the blood chapter, the respiratory chapter, nutrition chapter, but it's going to put a lot of information together and hopefully tie it all up for us. And at the end, we should be able to solve some acid-base balance problems. So water content. Now, the average person has about 40 liters of water in the body. And where this water is found is critical, and we'll talk about that as we go on. But infants, babies have the most water. They're about 75% or more water. They have low body fat and low bone mass, so they have the highest water content. Adult males have about 60% water. And why? Is because they have more muscle mass, and muscle is a water-based tissue, and so they have more water than females do because females have a higher fat content, less skeletal muscle mass, so females have about 10%, on average, 10% less water than males. Water content tends to decline as we age, and it can go down to approximately 45% as skin gets thinner and tissues dry out. It reduces the amount of water in those tissues. So total body water, 40 liters, and there's two main fluid compartments. There's intracellular fluid. That's where 2/3 of the water is found. That's what's inside the cells. Extracellular fluid is the water that's found outside the cells, and this makes up 1/3. And out of that third, you have plasma that makes up 3 liters, and then you have interstitial fluid. Now, interstitial fluid is the fluid that's in between the cells. And part of this interstitial fluid also includes lymph, cerebrospinal fluid, humors of the eyes, synovial fluid in joints, serous fluid in those serous membranes, and your gastrointestinal secretions. So those are smaller volumes that are contained within the interstitial fluid compartment. Now, this is the major sources of water intake and output. So average intake during the course of a day is about 2,500 milliliters, 2.5 liters. Most of the intake, about 2/3 of it, comes from beverages that you consume. So about 1,500 milliliters comes from the fluid that you take by way of the mouth. Now, food has a lot of water too. So about 750 milliliters comes from the food that you eat. And then this metabolism water, 250 milliliters, comes from that breakdown of glucose. Remember that when we talked about the oxidation of glucose, by adding oxygen with it, your byproducts are carbon dioxide and water. In the process, you're making a lot of ATP, but that's where that water of metabolism comes from, metabolizing glucose. Now, water output, 2/3, about comes in the form of urine. So that's where most of your water output goes. There's insensible loss. Insensible means you don't really recognize it's going, but about 700 milliliters goes by way of the skin and the lungs because air is humidified as you breathe it in, so it carries off some water volume with it. Sweat, about 8%, and there is some water in feces, which makes up another 4%. So that's where the water goes when it leaves the body. Now, regulation of water intake. The thirst mechanism is the driving force for water intake and is governed by the hypothalamus. That's where your thirst center is. So there are these osmoreceptors in the hypothalamus that detect the extracellular fluid osmolality. So it's talking about how much solute is in the fluid in the extracellular compartment. So if the plasma osmolality increases by 2 to 3%, this is enough of a change to stimulate those osmoreceptors to trigger the brain that you need to drink some water. Also, dry mouth will trigger it, decreased blood volume or pressure, and angiotensin II or baroreceptor input. Angiotensin II helps to increase blood pressure when blood volume is low. Baroreceptors respond to a degree of stretch on blood vessels. Those mechanisms will also encourage water intake. So, regulation of water output. Obligatory water output is referring to the amount of water that's needed to remove substances from the body. So to remove waste products, you need a certain amount of water. So to get rid of feces, to get rid of waste products in urine, you have to have a certain amount of water. Insensible is what we lose from the lungs and skin. We talked about feces, but you need about 500 milliliters a day in urine to excrete the waste products there. Solute volume and concentration of urine is a function of how much you take in, what your diet is, and water loss by other avenues. Disorders of water balance: dehydration, fluid deficiency. The extracellular fluid compartment can lose water due to hemorrhage, severe burns, prolonged vomiting and diarrhea, profuse sweating, water deprivation, diuretic abuse, endocrine disturbances, certain hormones that regulate fluid volume. These are important problems that can result in a fluid deficiency. Signs and symptoms: dry mouth, thirst, skin gets flushed, and oliguria means you're not producing much urine. This problem could lead to weight loss, fever, mental confusion, hypovolemic shock, and loss of electrolytes. Really have to watch people that are bedridden or housebound, elderly people, or people that are mentally impaired. They may not consume enough water, or if they're bedridden and can't really communicate, you have to pay attention to making sure their fluid needs are met. Now, there's another problem, not very common, but it's called hypotonic hydration, and it's where the cells are overhydrated and primarily caused by water intoxication. Now, can occur with renal insufficiency, where you're just not able to filter enough fluid through the kidneys, or if a person rapidly ingests a lot of water at one time. So this can cause a problem. And what it does is it decreases the extracellular fluid osmolality. And this will dilute sodium. And many times low sodium is not caused by too little sodium. Most people have more than enough sodium, but it's caused by dilution of the sodium by too much water. That's what the problem is. So edema can cause this, water intoxication, hyponatremia, which can result in problems. So that causes a net osmosis of fluid into tissue cells. It causes the tissue cells to swell, which can result in severe metabolic disturbances. And that can result in vomiting, nausea, muscle cramping. And the real problem is if you get swelling in the brain, cerebral edema, there's no place for that fluid to go because the brain's in the skull, and that can possibly result in death. There have been cases of people drinking extreme amounts of water that have died from cerebral edema. And the quick remedy is hypertonic saline, getting a lot of solute into the extracellular fluid compartment to offset this hyponatremia caused by the excessive fluid buildup in the extracellular fluid space. Edema. Any factors that accelerate fluid loss from where the fluid's supposed to be, inside the cells primarily or in the plasma. Increased blood pressure, capillary permeability, incompetent venous valves, localized blood vessel blockage, congestive heart failure, hypertension, high blood volume, imbalance in colloid osmotic pressure. Any of these can result in edema. Hypoproteinemia results from usually failing kidneys. So if the kidney filtration units are compromised, you'll spill off a lot of protein into the urine, and liver failure, because liver is where your proteins are made. Most of your plasma proteins are made there. So if the liver's failing, you're not making these proteins. So in either case, the proteins are the major solute that helps to hold the water into the blood vessels. So if you're losing protein in urine, you're not making the proteins from the liver, you are not getting enough of these plasma proteins to hold the water in, so water leaves the capillaries and causes edema. So hypoproteinemia is a major cause of edema with people that have failing livers. You hear it referred to as ascites, and then failing kidneys. Now, composition of body fluids. Water is the universal solvent, so most of your solutes are dissolved in water. Now, the solutes are either non-electrolytes or they're electrolytes. Now, your non-electrolytes are organic substances that do not come apart in water, like glucose, lipids, creatinine, urea. You don't make charged particles. Now, electrolytes are substances that dissociate into ions in water, like salt. Salt breaks apart into sodium ions and chloride ions. So inorganic salts, all acids and bases, and some proteins are charged particles as well. These can conduct an electrical current. Remember how we talked about nerve cells and muscle cells, that polarization, depolarization with the movement of ions, sodium and potassium. And they have a greater osmotic power than non-electrolytes because one salt molecule makes two electrolytes. So they have double the effect of one non-electrolyte. So they have the greatest ability to cause fluid shifts. This is how electrolytes are measured. They're measured in milliequivalents. And the milliequivalent, this is more or less a chemistry thing, so I'm not really going to talk to you about this. If you get into programs, you'll probably have to solve problems. We don't have time to do that in here, but it's based on molar concentration. So you're looking at the ion concentration in milligrams per liter, divided by the atomic weight of the ion, milligrams per millimoles, and then you multiply it times the number of electrical charges. That is a milliequivalent. And if you want to study more of that on your own, there's plenty of YouTube videos out there. Now, extracellular versus intracellular fluid. What is the pattern of solutes? Where are these electrolytes found? Some of these we already know. Extracellular fluid, your major cation is sodium. Your major anion is chloride. In the plasma, you have higher protein, lower chloride ion concentration. Intracellular fluid compartment, low sodium and chloride ions, but your major cation is potassium inside the cells, and your major anion is the phosphate ion. And you have more soluble proteins inside the cells than you do in the plasma. So your extracellular and intracellular fluid, your electrolytes are most abundant solutes in the body fluids, and they determine most chemical and physical reactions. The bulk of the dissolved solutes are proteins, phospholipids, cholesterol, and triglycerides, and in these three areas, this is how much is made up of by proteins, phospholipids, cholesterol, and triglycerides. 90% in plasma, 60% in interstitial fluid, 97% in these inside the cells, intracellular fluid. This little chart gives you an idea of where these major electrolytes are found, whether they're found in blood plasma, interstitial fluid, and intracellular fluid. If you look at this right here, you see that your potassium is mainly found inside the cells, and if you look at sodium, it's mostly outside the cells in the interstitial fluid, and it's very high in blood plasma. So just some examples, and you can look that over. Now, electrolyte balance. Electrolytes are salts, acids, bases, and some proteins. And electrolyte balance usually refers only to salt balance, because that's what you're going to be measuring, is salts. And these salts control fluid movements. They provide minerals for excitability, like in nerve cells and muscle cells. They are cofactors in secretory activity. Remember, we needed calcium channels to open to allow axon terminals to release their neurotransmitters, and they are involved in membrane permeability. Salts go into the body by ingestion. You take them in your diet and metabolism, and they're lost through perspiration, feces, vomit, and urine. So sodium is the most abundant cation in the extracellular fluid compartment. It actually contributes 280 milliosmoles of the total 300 milliosmoles extracellular fluid solute concentration. When they say that aldosterone regulates 95% of your electrolyte balance, this is the reason why. 280 milliosmoles out of 300 is 95%. So aldosterone is pretty important because it controls sodium, and sodium makes up a major part of the solute concentration of that extracellular fluid compartment. It's the only cation that really exerts significant osmotic pressure. So it controls the extracellular fluid volume and water distribution, and changes in sodium levels affect plasma volume, blood pressure, and extracellular fluid compartment values and interstitial fluid volumes. Very important. So what regulates sodium? Aldosterone. We already know this, but it doesn't hurt to review it. So regardless of whether aldosterone is present or not, 65% of sodium is reabsorbed in the proximal convoluted tubules. 25% is reclaimed in that ascending loop of Henle, which is the nephron loop. Sodium is never secreted into filtrate. Water infiltrate follows sodium if ADH is present. So increase sodium in the urine, you're going to increase water loss. So renin catalyzes the production of angiotensin II, which prompts aldosterone release from the adrenal cortex. That's going to increase sodium reabsorption by the kidney tubules in the region of the distal convoluted tubule and the collecting duct. Aldosterone release also triggered by elevated potassium levels in extracellular fluid space, because remember, sodium and potassium are on an exchange system. Aldosterone is slow. This is a slow hormone to bring about an effect. It takes hours to days. This is looking at mechanisms and consequences of aldosterone release. Over here you see if potassium levels are high in the extracellular fluid, or if you have a low body sodium content, which triggers renin release and increases angiotensin, either one of those can bring out the same effect. It'll stimulate the adrenal cortex to release aldosterone, targets the kidney tubules, and the kidney tubules will cause more sodium to be reabsorbed, and at the same time get rid of potassium, and that's going to restore the homeostatic plasma levels of sodium and potassium. So ANP, atrial natriuretic peptide, released by the atrial cells in response to stretch, increased blood pressure. The effects: decrease blood pressure and blood volume by counteracting the release of ADH. So you're not going to produce ADH, you're not going to produce renin, you're not going to produce aldosterone. That's going to cause you to excrete more sodium and water, promotes vasodilation directly, and also decreasing production of angiotensin II. So the idea is to get rid of water and decrease blood pressure. There's other hormones that have an effect. Female sex hormones. Estrogen tends to cause you to retain salt. It works like aldosterone, and this accounts for water retention during different periods of the menstrual cycle, why some women get bloated, and also during pregnancy. It makes a person gain weight and retain fluid. Progesterone works the opposite way. It blocks sodium reabsorption and blocks aldosterone, and it promotes sodium and water loss. And then there are things like glucocorticoids, prednisone, medication, cortisol. These will increase sodium reabsorption and promote edema, and that's why people that are on prednisone for extended periods of time tend to just swell up. They get bloated. Potassium. Now, the importance of potassium is that it helps with muscle and nerve, that depolarization, repolarization process, okay? And you need potassium to repolarize the membranes. Now, potassium is primarily found inside the cell, but out of all the electrolytes, it's the most permeable through the cell membrane. And this is going to be important because either way that potassium goes can affect what happens with the ability of the cell to respond. So it affects the resting membrane potential in neurons and muscle cells, especially cardiac muscle. And remember, it's found outside the cells. So if you increase the extracellular fluid volume of potassium, the resting potential becomes less negative, because if you have too much outside, the potassium is going to go inside. It's permeable through the membrane. And what that's going to do is it increases the excitability, and it causes hypopolarization of the membrane. So what it does is it raises that resting potential. It makes it less negative inside, so it makes the membrane more irritable. Now, if there's too little outside the cells, then what happens is the potassium from the inside of the cell moves out. So that hyperpolarizes the membrane. It makes the potential inside the cell more negative, and it makes it non-responsive. So the term hyperkalemia means too much potassium, and hypokalemia means too little potassium. Both can disrupt the electrical conduction in the heart and result in sudden death. So too little or too much potassium can be lethal. This picture gives you an idea of what's going on. And this is normal potassium levels outside. And what happens is the arrows are the same side, so you have equal diffusion in and out of the cells, and your resting potential stays normal. There's your resting membrane potential. Now, hyperkalemia, what happens is if you have too much potassium outside the cells, then you have less going out and a lot more going in, and that's going to elevate the resting membrane potential, which makes the cells partially depolarize, and the cells are more excitable. So that's hyperkalemia. Now, hypokalemia, you have reduced extracellular potassium concentration, so more is going out now, and that's going to result in hyperpolarization. It drops that resting membrane potential, and the cells are less excitable. So either way is going to cause you a problem. So the regulation of potassium balance, potassium is part of the body's buffer system. And it's on an exchange system with sodium, and it's also on an exchange system with hydrogen ions. So if you have acidosis where the H ion level increases in the blood, what will happen is that the cells will try to offset this by bringing hydrogen into the cells in exchange for potassium, because potassium is normally found inside the cells. So if you shift these two, potassium doesn't contribute to acid-base nature of the blood, but hydrogen does. So what happens is if you have acidosis, then the cells will take in the hydrogen and release the potassium out into the plasma. So potassium levels will rise with acidosis because of that exchange. And if you have alkalosis, then the cells will release hydrogen ions outside the cells and bring potassium in. So potassium levels fall with alkalosis. But that can interfere with the activity of excitable cells. So this shift for acidosis, alkalosis, can ultimately affect what's going on outside the cells because you're disturbing that potassium level. Chloride ions. Chloride is the major anion accompanying sodium in the extracellular fluid compartment. During acidosis, chloride ions are secreted in exchange for bicarb. See, bicarb is a base. Chloride ions don't have any acid-base characteristic. So when you have acidosis, you want to hold back the bicarb because that's a base. So you hold that back and you exchange it for chloride ions. So imbalances in chloride ions usually are rare. And hyperchloremia is usually the result of too much intravenous saline. And hypochloremia, usually a side effect of hyponatremia, which is usually caused by too much water and dilution of sodium outside the cells, which will do the same thing to chloride ions. Calcium. 99% of the body's calcium is tied up in bones and calcium phosphate salts. Calcium in the extracellular fluid compartment is important for the following things: blood clotting, cell membrane permeability, secretory activities, neuromuscular excitability is the most important. Hypocalcemia increases excitability and can result in muscle tetany. Hypercalcemia inhibits neurons and muscle cells and may cause heart arrhythmias. Calcium balance is controlled by parathyroid hormone from the parathyroid glands and rarely deviates from normal limits. PTH. PTH is important to increase calcium levels by targeting bones, makes the osteoclast break down bone matrix, releasing calcium and phosphate into the bloodstream. We've beaten that dead horse to death. Kidneys. PTH will increase calcium reabsorption and decreases phosphate ion reabsorption. And then in the small intestine, it increases calcium absorption directly through stimulation of the kidney to activate vitamin D precursor. Remember, vitamin D is a very important player in calcium reabsorption. Now we're going to get into acid-base balance. And I am hopeful that by the time we get to the end of this, that you will have a basic understanding. And then from this, what I want you to do is I want you to look at that acid-base calculator that I have under Chapter 26 resources and do some problems. You need to practice with problems to get an understanding. We're going to cover the basics, and then you can use the calculator, and then let me know what questions you have. pH affects all functional proteins and biochemical reactions and is very closely regulated. Normal pH of body fluids, arterial blood, the mean is 7.4, but the range is 7.45 to 7.35 to 7.45. Venous blood, interstitial fluid, 7.35, and intracellular fluid is 7.0. But what we're going to be talking about is we're going to be talking about this acid-base balance that occurs in the blood. And the range is 7.35 to 7.45. If it falls above 7.45, we call that alkalosis or alkalemia, a basic nature to the blood, increase in base content, okay? So that's 7.45 and above. Below 7.35 is considered acidosis. The blood's becoming more acidic, or called acidemia. So just remember, anything less than 7.35, acidosis. Above 7.45, alkalosis. So acid-base balance, these are chemical buffer systems. Now, chemical buffers are usually things that are acids that can dissociate, and they can also mop up excess acids or bases, okay? Strong acids are acids that can dissociate. They fall apart completely in water, and they can dramatically affect pH because they completely fall apart. Weak acids dissociate only partially in water, and these are efficient at preventing pH changes because they can act as a buffer, so that's really important. Strong bases dissociate easily in water, and they quickly tie up H ions. Weak bases accept H more slowly. So let's just look at a picture form of this. Hydrochloric acid, HCl, when that comes apart into electrolytes, it's a strong acid. It completely dissociates, and it releases a lot of H's in solution. You see, the more H's that are in solution, the stronger the base. Stronger the acid, right? A weak acid, they don't all fall apart, so you don't have that many H ions here, so it doesn't dissociate completely. This quickly makes changes, this slowly makes changes, and for that reason a weak acid makes a really good buffer because it can bind up some H's in solution. So we have different chemical buffer systems. We have, and a buffer system is a system of one or more compounds that act to resist pH changes when a strong acid or base is added. It binds H if the pH drops, because remember H is an acid, and it releases H if the pH rises. So we have the bicarbonate buffer system, the phosphate buffer system, and the protein buffer system. This is the one we're going to focus on in this chapter because this is the most important system for regulating acid-base balance. The phosphate buffer system, phosphate can bind up H's and take them out of solution, and it can go out in urine. So this one can carry away H's and regulate pH. Proteins, some proteins can do the same thing. So this system is the one we're going to focus on. So physiological buffer systems. The respiratory system eliminates CO2. So the respiratory system controls CO2, which contributes to acidity. Now, there is this reversible equilibrium that exists in the blood. This equation should look really familiar because we've had this several times now. We've had it in the respiratory system, we had it in the blood transporting CO2 and red blood cells, but CO2 can combine with water and form bicarbonate. Carbonic acid. Now, carbonic acid is a weak acid. We just saw that in solution in the previous picture. And if this gets overwhelmed, this buffer system here, this carbonic acid, that breaks into H ions and bicarb. This part of the system is controlled by the urinary system. The kidneys regulate this, and the lungs regulate this. So you want to remember that the lungs and the kidneys are the most important systems in regulating this particular balance, this buffer system. So CO2 is regulated by the respiratory system. Bicarb and H ions are regulated primarily by the urinary system, and they call this metabolic. So we're going to have respiratory issues, and we're going to have metabolic issues that we're going to talk about. So chemical buffers cannot eliminate excess acids or bases from the body, but they bind them up. Lungs eliminate carbonic acid by eliminating CO2. Kidneys eliminate non-volatile or fixed acids produced by cellular metabolism. They can get rid of phosphoric acid, they can get rid of uric acid, lactic acid, and ketones to prevent metabolic problems, and these would contribute to metabolic acidosis. So the most important renal mechanisms conserving or generating new bicarb are excreting bicarb. And generating or reabsorbing one bicarb is the same as losing one H, and excreting one bicarb is the same as gaining one H. So the effects of acidosis and alkalosis can be profound. A blood pH below 6.8 can cause depression of central nervous system and result in coma and death. So acidosis is nothing to be played around with. Blood pH above 7.8 can cause excitation of the nervous system, muscle tetany, extreme nervousness, convulsions, and death from respiratory arrest. So either way, acidosis or alkalosis can be fatal. So this is going to give you a little overview of what is going on with acid-base imbalances. Now I want you to remember, and maybe write this down, that your normal blood pH, the range is 7.35 to 7.45. Anything below 7.35 is considered acidosis. Anything above 7.45 is considered alkalosis. Now, if you have inadequate ventilation, say somebody has pneumonia or they have emphysema and they're just not getting good gas exchange, then that will increase carbon dioxide levels, which is going to result in a lower pH. Respiratory alkalosis, the main cause there, that's not as common, but hyperventilation. If you're breathing very heavily, you're going to be removing a lot of CO2, and so that's going to increase the pH. Now, your levels of CO2, your normal carrying load for CO2 is 35 to 45 millimeters of mercury. So, if CO2 levels rise above 45, that's going to be respiratory acidosis, okay, above 45 millimeters of mercury. If it goes below 35, then we call that respiratory alkalosis. pH is going up. Now, Metabolic changes, and this is changes in bicarb. Your normal level of bicarb is 22 to 26 milliequivalents per liter. It is a charged particle, so it's measured in milliequivalents. So, if your bicarb is low, bicarb is a base, then your pH is going to go down. So anything below 22 milliequivalents per liter is called metabolic acidosis. Excessive alcohol consumption can cause it, persistent diarrhea, ketosis, kidney failure. All these things can result in metabolic acidosis. Metabolic alkalosis is where you have an increase in bicarb, and that's anything above 26 milliequivalents per liter. Because it's a base, your pH will go up, and excessive use of antacids can cause metabolic alkalosis. So spend some time looking at this and getting familiar with what CO2 levels do if they're high or low, and what bicarb levels, what happens if it's high or low, and the terminology that connects them together. This is controlled by the lungs. This is controlled by the kidneys. So using blood values to determine the cause of acidosis or alkalosis, the first thing you do is you check the pH. And if the pH is below 7.35, you know the problem is acidosis. If the pH is above 7.45, then you know the problem is alkalosis. So then, usually you're given three values. You're given the pH, you're given the CO2 level, and you're given the bicarb level. Now, we know the pH level, 7.35 to 7.45. We know that CO2, the level that's normal, is 35 to 45 millimeters of mercury pressure. And then you got to check, you got to look at the you have to look at the bicarb. And bicarb level is 22 to 26 milliequivalents per liter. So after you check the pH and you determine whether it's in the acidosis range or alkalosis range, now you're going to check the CO2. The respiratory system is fast acting, so a high or low CO2 may indicate that the condition is the respiratory system, caused by that system, or is compensating. So, example, if the pH is acidosis, then if the PCO2 is above 45 millimeters of mercury, the respiratory system is the cause of the problem, and the condition is a respiratory acidosis. If the PCO2 is below 35 millimeters of mercury, and it's not the cause, but is compensating, okay? If the PCO2 is within normal limits, the condition is neither caused nor compensated by the respiratory system. Now, check the bicarb level. If it's metabolic acidosis, then your bicarb is lower than 22 milliequivalents per liter. If it's metabolic alkalosis, then your bicarb is above 26 milliequivalents per liter. So here are some problems. The pH is 7.63. So my problem is alkalosis, and you look to see what system is causing your problem. So my CO2 is 19 millimeters of mercury, and 19 is low, and low would be alkalosis, so that could be causing the problem. This is 19.5, which is low, which is acidosis. So your problem, your alkalosis, is caused by your low carbon dioxide level, and your kidneys are trying to compensate by getting rid of bicarb, which is a base. And so this is partial compensation. If this system was in the normal range, because this is the cause of your problem, the low CO2, if this was normal, if it was, say, 24, no compensation by the system. If it's out of range, opposite the direction of your problem, because this is an acidosis, then it is partial compensation. full compensation would mean that the pH is back in the normal range, which it is not in this case. So the answer to this problem is respiratory alkalosis and partial compensation by the other system. The metabolic part of this is trying to compensate, but it's not fully compensating because the pH is still off. Let's go to the next one. pH is 7.22. What does that mean? That is that is acidosis. My CO2 is 30. That is low, which is alkalosis. And your bicarb is 12. That's low, which is acidosis. So the cause of my problem is a metabolic issue with the kidneys, and that is metabolic acidosis. I do have partial compensation by the respiratory system, which means that respiratory rate is picking up, blowing off more CO2, and it's raising the pH to try to compensate for this acidosis. Not full compensation because the pH is still out of range. Now what I want you to do is use the calculator that is in Chapter 26 resources and practice some problems, because you will have a problem on the test. It's not going to make or break your grade, but this is such an important part of the first semester of nursing that you really want to at least carry forward a little understanding of this. And if you have questions, let me know and we can talk about it.